Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
EMS doesn't work alone. Every call is a shared space between agencies, priorities, and legal systems. And how well we move inside that space shapes patient outcomes and professional survival.
We're not just talking teamwork, we're talking liability, documentation, and how entire systems judge EMS.
This episode is about the reality that every uniform around you changes what your care, your chart, and your career mean.
So in this first section, we're just going to be talking about why the heck co-agency responses exist, because I think all of us sometimes have been like, just everyone get off the scene.
Yeah, go away.
Get off the scene.
Shoo.
So more than 70% of 911 calls actually involve at least one other agency, which makes sense. Depends on, what part of the country you're working in. But those include like fire, law enforcement, both. EMS is not the first not a first responder in isolation, obviously. And when I worked on the fire department, especially when I was volunteer, we were called the first responders, and then EMS and police were almost secondary.
Secondary, yeah.
Yeah. So let's dive in.
Yeah, I like we're the medical arm of a multi-agency machine.
100%. There has to be a lot of moving parts, and how well we work together matters. So that's why we're talking about this today, because this is a lot of the time where tension rises.
Yeah.
And we're going to use our own experience, which may be different from y'all's. We don't necessarily work in a system that does tiered response. We respond the same way to every single 911 call. But in some agencies, they do that. So just take some of what we say with a grain of salt, and as it applies to your agency or system may be different.
Yeah.
And as we've all worked in EMS for quite a while, we know that there are certain calls that almost always we get other responders on. What are some of those that we might see, police or fire on for sure?
Cardiac arrests.
Definitely.
Most
Need hands.
overdoses. Traumas.
Car wrecks.
For sure, car wrecks.
Well, and we've been able to see kind of a difference in this, because I know when I first started at this agency, it was just select calls that fire would come on.
Yeah.
And then kind of throughout the years, it's progressed to fire first response to all medical calls. So obviously the police do not respond to all medical calls, so there's still some
Sometimes
specific.
They get dispatched and I didn't even know it, and then I show up and I'm like, what are y'all doing here? Is there something we need to know?
Yeah.
Literally, what's going on?
Absolutely. I'm like,
no.
did we miss something?
My favorite is when we get a behavioral emergency at a nursing facility or a memory care center, and the police are dispatched, because it may have been the reason they called is because they hit another resident, so then it's an assault, and it just is kind of funny to me.
Yeah, and sometimes, especially if they have a longer response, one of the nursing home that's in the county.
Yeah.
And SO has a prolonged response.
And they're just standing there
and they'll be like, do you guys still need police?
No.
And we're like, no.
I think we're all
Didn't even know you were coming.
Yeah.
Sorry about that.
We do. They're like, EMS stage. And I'm like, I think the granny.
We're okay.
I think we got this one.
Yeah.
I understand the reason behind,
Right.
like,
And same way every time. That seems appropriate.
yeah, like let's just send them. We send them on every single one. You stage on every one. Like I get it, but there are definitely periods of discretion where you're like, guys, I don't need to.
Sometimes those grannies be getting super strength. I'm
Oh, they
telling
do.
ya.
They do.
Their nails.
They
oh
do.
my gosh,
They will draw
deadly
blood.
weapon.
That
Deadly
you get a
weapon.
granny grip on your
Mhm.
forearm, they will dig
It
into
could be
you.
dangerous.
They mean it,
Mhm.
and you just feel bad trying to like break their grip because you don't want to hurt
Right.
them.
Yeah.
And
Yeah.
so you're like, can you? That is uncomfy. What about like MBCs? I think this is a great example of multi-agency response.
Especially when there's critically ill patients.
Absolutely, because it's like your jurisdiction is so crazy. So like the patients belong to EMS. The scene belongs to fire. All evidence, traffic control, people involved, all belongs to PD.
I think that's a good way to break it down.
Right.
Everyone just rewind and listen to that one more time.
Right.
Yeah.
And so like that makes it really tough because we'll find ourselves in a situation sometimes where like I have 2 patients, both entrapped. I can get myself into the vehicle. I can't get them out of the vehicle.
Right.
Fire is technically in charge of that scene and its safety. And so they're within their right to be like, you can't get in there. But I'm the lead medical
that
provider.
frustrates me. That makes me like,
Right.
especially when they're not please just talk to us. Tell us if our patient's awake, if they're able to answer questions, if there's controlled bleeding or uncontrolled bleeding. Like, just that
Absolutely.
kind of stuff.
But
it,
I'm
it
not.
eases our mind.
Yes.
My mind, at
and like
least.
I'm not going to not make contact with my patient. So I'm going
Right.
to get in that vehicle and I'm going to go make contact with them because we may have to do things while you're trying to extricate.
Remember that time I got screamed at?
Mm-hmm. I got horse
And
collared.
I was I'm just going to say this really quickly. I was the highest
Mm-hmm.
certified extricator on that scene, but I was medical. And I literally got screamed at to get away from my unresponsive patient.
Uh-huh.
Mind you, I wasn't in like turnouts because as medical we didn't have those, but I think it was like COVID, so I had like goggles on, and I'm pretty sure a firefighter gave me his helmet.
Yeah.
So like I was not in danger.
Oh yeah.
Okay.
I got horse collared one time by a captain on scene.
That's what
because
happened to me.
I was
Just,
trying
like,
to get
I was like,
into
Okay.
a vehicle.
That's assault.
Yeah, with an unresponsive patient, and they were trying to like cut his door off. The guy that had the cutters and myself were like communicating. Like I
Yeah.
knew where he was cutting. He knew where I was
Absolutely.
standing. Like we were good.
Please don't assault me unless my
Yeah.
life is about to end.
Absolutely. But like there's situations like that where I understand that your biggest concern
Yeah.
right now is one, getting this patient out and keeping us all safe. And there
Yeah.
are
And
there
that's
are
hammered
moments,
into your head,
yeah.
right, as
And
a
there's
firefighter.
moments where like us getting in the car is not really plausible, but there's a lot that it is plausible, and we need to work together to figure out how to do that safely, because I get that
Absolutely.
you have like medical responders, but no fireman wants to stop cutting something to go manage a medical
And
patient.
that's just the reality of it.
Yeah, so like let me in there. And so that's a huge
And
point
if
of
you
contention.
are going to send someone in, right, you're a fire crew and you're choosing who is going into the car, please choose the paramedic
Yes.
that's on your team,
Yes. And that is almost never the case, because the
Right.
medic is always,
like the captain or something.
yeah, they're
But
always like
please try.
a decently high rank in the fire department, and they want to cut things.
Right.
I was going to say, though, I think that where we see the most definition of everybody's role on like a car wreck is like super critical calls, where there is like extrication that needs to be done. There is traffic that needs to be controlled.
No
like
one
I'm-
teaches you that.
No. And I'm thinking of like, let's say a very significant wreck on like an interstate where
Mhm.
there's significant traffic control needed, there is extrication needed, and there are critical
Mm-hmm.
patients. That is like, it's always very defined. Like EMS always goes and does patient care.
Yeah.
Fire is very concentrated on extrication efforts, and PD is always like collecting evidence,
Yeah.
doing traffic control, all of those things. But like, why can't it be like that on every scene?
On every scene.
Yeah.
So
You know?
we had a experience. It was a very large scale MVC, and it happened to be with our favorite fire shift, which was wonderful. But it was such.
We don't pick favorites. What are you talking about?
But there were such there was such good communication, because there was multi-agency response. So they had like the highway patrol, sheriff's office, city PD, city fire, us. I mean, we
I'm actually
just-
surprised because when there's that many agencies,
Yeah.
it kind of gets a little nuts.
it can
sometimes.
be wild, and everyone did a decent job of like setting up scene command. We were like communicating with each other, which was great. And then you could see fire, and they were working through extrication, and then one of our medics was actually in the vehicle triaging patients. And so that was a really cool moment because fire was deferring to him to be like, where do you need us to cut? Like,
Yeah.
Communicate with each
where
other.
do we need to start getting
Our
the
goal
things
is
out?
to save lives.
And then
All
fire,
of us.
he was communicating with fire, like where these patients are located. And then they were communicating back with him, like where it's safe for him to be.
Yeah.
And it was just a really cool moment for all of us to work together. Nobody was fighting over who's in charge. Nobody was fighting over whose patient this is. Like, it was just everybody had clear and concise roles. PD was on it with traffic control. They were asking about, do we need to land a helicopter? Like,
Good.
what are we doing?
That's how it's
Everybody
supposed to
had
look.
it together.
Doesn't that make you proud?
Yeah.
Yes. And I'm like, can we please do this on every single medical call?
Somebody follow us around with a camera so we know
Mhm.
how to repeat this scenario.
Absolutely.
But that brings us to our next point, which
Mhm.
is we're going to discuss and break down, the interaction between fire and EMS and then police and EMS.
Yeah.
So, as we've kind of already talked about, fire departments control hazards and access and can initiate medical care if capable. In most every case, EMS controls the medicine. When those two worlds collide, patients live or die based on how well those teams cooperate.
For real, and we've all seen it.
Mhm.
Absolutely. And we all have examples of how that's gone really, really well. And we all have examples of how that has maybe faltered.
Yeah. I think that where I get frustrated with fire and EMS interaction is that if I respond to a fire scene, I'm super respectful and super aware that that is not my scene, that I'm there as support, right? And so it does not matter if, like, a lot of our EMS partners have a lot of extensive fire training.
Some of them are still firefighters.
Yeah,
full
some of them
time.
still are. But that does not matter because that's not the role that we're currently in.
Right.
And so whenever we respond to fire scenes, like, we make sure that we park our ambulance respectfully. We make sure that we ask if there's anything that you need. We try to be helpful, but not in the way. Like, that is our goal. And so in those moments, like, we're not just pulling hose off trucks because we know that it needs to be
we're not just
pulled.
opening hydrants because
Yeah.
we know how.
Absolutely. And so there's stuff that EMS does on fire scenes that we do respectfully. And where I sometimes have a problem is when the roles are reversed. I don't think fire sees it that way.
No.
They don't see, like,
I
I'm
agree.
responding to a medical call, so this is EMS's scene. They still think it's their scene. And where we end up running into problems is when, like, they take the door and they park it in front of the driveway and they park in front of the sidewalks. We have, like, a stretcher, so we have to access homes and access entrances. And so, like, that's just not very courteous.
Yes.
And then we get there at the same time, but you sprint into the house. And so now the patient has to repeat whatever it is that they just told you. And you don't really want to get, like, a secondhand story. You want, like, the patient. And then if you have multi-levels of responders, so, like, they also have medics and things like that, sometimes there is a issue with handoff. And so that the fire medic assumes that it's their patient until they leave, which is not true. It's always the transporting medic's patient. And so that is kind of the hierarchy of who's in charge. And I think that can sometimes be a huge point of contention. And it shouldn't be. It's just command structure.
And it's not even, you don't even have to, it is command structure, but if you don't have to even look at it that way. Just put yourself in our shoes. What if you had the nozzle and I said, well, I am a firefighter too also, so I'm taking the nozzle. Get out of here.
Yeah.
What? No.
Scram.
Just because scram.
She doesn't want to talk to you.
Just because you can doesn't mean you should. And the same thing goes, like, if we're right behind you, right? And the way that we have always operated is because we were, like, I would say suburban, but closer to urban in the area, the district, the region. We're very close behind fire, if we're even behind them at all.
Yeah, it's either we beat them, we're the same, or we're like a couple minutes. Yeah.
And that's, again, just because you can doesn't mean you should. You're a medic too in a lot of these scenarios, right?
For sure.
So please establish what you would do if you were on the ambulance. You did rides on the ambulance. ABCs. Let's get vitals. And unfortunately, like you said, we have been to cases that exhibit, like, the opposite of perfect, the opposite of what collaboration and teamwork looks like at the expense of the patient. I've been to calls where they didn't even get vitals, but they got a blood sugar, and the blood sugar was low. So they just started treating that. And, Ashley and I get there, and we're like, guys, like, she's snoring.
Her SAT 60.
Yeah, like, I was like, is there a pulse ox on her? And they were like, no. Okay.
Okay.
Just like ABCs. Just start
Yeah.
where you would start if you were on the ambulance. And
Yeah.
if you get to the big scary thing because it's for a weird reason taking us 10 years to get there, then move on to the next step. But don't skip steps just so EMS is not initiating the intervention, because that has happened.
Oh yeah.
It's not a race.
And it's not often. It's not super
No.
frequent. But there has been medics that are on the fire side that want to do medic things. And I get it. I want to
We
do
can do
medic
medic things together.
Yeah, like I get it. It makes me excited.
Yeah.
But not at the expense of your patient. So like you have a cardiac arrest, airway is not your first intervention. Your first thing you should be doing on a cardiac arrest is not getting a tube.
Yeah.
That is a big no-no. You need to get CPR and get access and get meds in, and like all of those things are far more important.
Go in order.
And when you see providers show up and you're 1 minute behind them and they already have a blade in a patient's mouth, like that's an inappropriate timeline of intervention.
Yeah.
And it's just because you wanted a tube. It's
And
not because it was what was best.
And if you come to me and be like, listen, I really want a tube, I haven't gotten one in a while, or I've never gotten one, like outside of school, let's go, bro.
Let's do it.
Let's do it.
Hell
but like
yeah.
we have to like talk about it.
Yes. And,
Yeah.
it should be at the appropriate time.
Right.
You know, and I think that we run into that a lot. And for me, it just comes down to like respect.
Respect is
I
the
have-
biggest part.
Yeah, I gotta tell students a lot when they ride with us, like I am clear, concise, and direct. And sometimes that comes off like I'm a bitch. And I promise.
Only because you're a girl.
Right? And I promise I don't mean it, but like it is kind to be clear. And I want to make sure that everybody knows exactly the same page. We are all exactly on the same page.
Also, there
where
are
we need to
literally
be.
lives on the line, guys.
Yeah. And so if I
It is
tell
a little
you,
bit serious.
yes. And if I ask you to do something or tell you to do something, that's the reason why. And what we have run into decently frequently is tantrum throwing.
Let me tell you, it doesn't change when you get on the helicopter.
Right. We have run into co-responders that I will ask them to stop doing some intervention that they're doing because it's more appropriate for me to do it, and to start doing a different intervention, or I have a different plan than what they established prior to our arrival, and they will throw a tantrum. Like they will throw down the equipment, they will storm out of the room, and it is wildly inappropriate and it happens so often.
Also, not every moment is a learning moment. Sometimes it is most appropriate for the most skilled, the most competent, and the person with the most like reps to perform an intervention, and that is okay.
Yeah, sometimes we just have to get it done. And it's not all the time, and it doesn't happen on every call, but it happens so much more frequently than it should.
Yeah, I
And
agree.
why are we throwing tantrums?
Especially when there are cases, which I wrote this down. When, like, have you ever been on a call and you're like, we might have like a relatively sick patient, and then they hear another crew get dispatched to a fire, and they're like, we gotta go, there's a fire. I'm like, I'm sorry.
Okay.
What? Can you guys help us get her out first?
Yeah, can you like help me
So-
clear this person?
Just because we're all here to do, you know, the job that it is, which is to provide life-saving intervention when it matters most. But we're also here to do the job that we were dispatched to.
Yeah.
And sometimes it's not that fun.
Yeah,
And that's okay.
Like there are plenty of times that we get sent to a tummy pain and then a multi-vehicle MBC rollover with 2 ejections comes out and it's in our zone.
And it's literally like another crew from another, like across
And you're like-
town. And you're like,
And guess what? We still have to transport.
we can't just be like, you know what, fire, you handle it. We're leaving.
See you later, bye. Like we still have to transport Granny with tummy pain, and I know it's not fun,
Yeah.
but like if you're on this call, and sometimes they do it very respectfully. They'll be like, "Hey, like there's a fire.
If you are
guys
nice about
need
it, I'll be
us."
like, yeah, go get 'em, boys.
Yeah, y'all go
Go
play.
get 'em,
Yeah.
brother.
Yeah,
They're like, hey, can we please?
yeah, like y'all go have fun. I know that's
Yeah.
the job you want to do,
But when you just like be like, we're leaving, bye, I was
Deuces.
like, oh, you hate us.
right?
You
And
hate me.
that's what I think for me it comes down to respect.
Yeah.
Like just
we gotta do sucky
Yeah.
stuff sometimes. We
Just-
gotta miss out on fun stuff.
be respectful and understand the stressful aspect that comes from being fully responsible to every single intervention that happens, whether it's prior to arrival or after our arrival. I think that a lot of times paramedics forget that I have to answer for what they do.
Yeah.
And
And
so-
I may have to undo what you did.
Right? And that's tough because there's not going to be a situation where they provide an inappropriate intervention. I'm still the one that has to answer to it at the
Yeah.
ED. So like that's a hard time for me.
I would like to point out, I think, a big systemic failure that has a lot to do with that. We were talking about this the other day about how now we thankfully have a system that allows us to see outcomes, at least at most of the hospitals that we transport, which it's not a very detailed outcome. It's a very broad kind of what they got discharged with or where they got transported to in their final diagnosis.
And if they're dead.
And if they died.
Expired.
Yes.
Sometimes
the
is a
worst.
surprise.
That is the worst thing.
That is
Side
the worst
note.
thing to surprise see. I will say, because of that kind of took off the stress, if this was stressful to you, if this was something that was important to you, to follow up with that specific hospital to get the outcome of that patient that you were suspicious of, whatever disease pathology was going on, right?
Mm-hmm.
That was kind of your responsibility. And it didn't always happen. If you run 15 calls a shift, my God, you're not able to follow up on every single patient, right?
You don't even remember what happened this morning.
Exactly. So that would leave, I believe, EMS providers with a lot of either like false confidence of like disease pathologies that they really thought was going on with this patient, but maybe was never confirmed, but they never got an
They
outcome
don't know
either
if
way.
they were right or not.
Think about that.
Mm-hmm.
Think about never having
The
that.
complete blindness.
Complete blindness, and that's on the fire side. The only time that they ever get patient outcomes is if they reach out to us and we know about the patient outcome and then we then tell them.
Yeah.
So I do think that it is a big systemic failure, especially when we're talking about like firefighters that are first responding and initiating interventions. I will throw them a little bit of a carrot.
Yeah.
They never get to see a little carrot. They never get to see the outcomes of those interventions, even to the point of the outcomes when you breach hospital doors.
Yeah.
Which for us, there are many interventions
when
that
they
we
come
do. Yeah.
When they have to ride with us and they all come in, I'm like, do you see this? It's crazy in
It's
here.
wild. It's a circus in here. For us, there's a lot of interventions that we do that we can see by the time that we get to the hospital, and that, again, works into all our biases and our differential diagnoses and all of that. They don't even get that.
Yeah.
So a lot of the times, their interventions that they are doing, for lack of a better term, are blind. It is textbook. It is, I know that if I see this, I do this, which maybe with other experiences or other knowledge or, anecdotal experience, maybe you would choose a different path.
Yeah. It's hard to develop intuition that way.
Absolutely.
Yeah.
Which again, I think that is a systemic failure. But with all of that being said, typically the transporting medic does have more anecdotal experience.
And the transporting medic is medical command. And I know some systems, the medic will literally get off of the fire truck because you're like a combined system and ride in. But that then means that medic is the transporting medic. So in all cases, I would say, very, very rarely, I don't know a situation truly off the top of my head that would be different. The transporting medic is medical command.
Oh, absolutely.
Say it with me. The transporting medic is medical command.
And that also that just makes sense.
Yeah, it does.
Just makes sense. This is who's going to continue this care. This is who is going to give report to the ED. This is who's going to document this entire process.
You're right.
It makes sense
It's
that
easier.
the transporting medic is medical command, because it would be so silly for the non-transporting medic to be command, because then do you just transfer command when they get into the ambulance? Because then there's only one medic in there.
Yeah.
Like, it doesn't make sense.
Yeah.
And
It's
so
confusing. And it's hard for patients.
Yeah, agencies that do it that way is strange to me. We've talked about this before. With fire has a very specific command structure and a very specific hierarchy. And so it is literally like, depending on what your rank is, like, that is who is in charge. Your captain tells you to do something, you don't talk back, you do what your captain says. When you get on an EMS scene,
absolutely not.
It's really different, because that fire captain may only be an EMT basic. And so, like, his rank is not what's important on this scene.
Also, at the end of the day, who are you answering to?
Right. So
your medical director.
Right. That gets really confusing. Like, your captain, who's an EMT basic, may have told you to start an IV.
That's fine.
But I'm a critical care medic, and now I'm here, and I'm like, I actually
don't need that.
Would like you to bag the patient.
Or, let's bag them first, and then we'll address access, whatever it is.
Plans may change.
And they will still turn to look at their captain, because I understand that's how you're taught. But currently, I'm going to be so honest, he has no say in what we do because the transporting medic should be your scene command.
And the same thing happens when you end up at the hospital.
Yeah.
Mhm.
I don't just be like, no, doctor, don't do that.
Yes.
Like, it's now their turn.
When we get there, now
Yeah.
all of a sudden the doctor is like, all right, do X, Y, and Z. Even if I disagree with it,
Yes.
Dr.
I could be
Man.
like, that is really dumb.
Yeah, I'm like, ugh. But like, doctor is Dr. Man.
Yeah.
Or Dr. Lady.
Mm-hmm.
So I think that that's really interesting. And I wish that they had like a medical call response command structure.
Like on the fire side.
Yes. So like, let's say that your firefighter 1 is a medic. And
Firefighter number 1,
yes.
by the way, not the
not the
level
level.
of training.
Yes, like firefighter number 1 is your medic, but he's technically the rookie on your truck. So like he has the least amount of say on this engine or ladder or rescue. But then when you get to a medical scene, he's now the highest license. So now he has the most say.
Yeah.
And that's really confusing for a structure that's not built for that.
Yeah.
Yeah.
For sure.
But there should be something in place so that that is not questionable.
Yeah,
You know
that should
who,
be like a hard line.
Yeah, like you should know who your like medical command on your truck is.
Well, that would be like saying you work with an EMT who's been an EMT at this service for 20 years, but you got your medic 2 weeks ago. Someone still has to ride in the back with the critically ill patient, and it's the paramedic.
Yeah.
I mean, it's just how license works.
For sure.
Mhm.
And I think that that's where a lot of people get confused with co-responses is because we operate, now obviously we have a chain of command,
Yeah.
but we operate off of licensure,
Mhm.
not rank.
Right.
And that gets really confusing when your licensure and your rank don't match.
Well, even when it comes to rank, right? If your supervisor
You have
shows
to
up
have.
on scene, like, they are not your they're still not your medical direction. So if there's a question, we still have to call the doctor.
Mhm.
Like, it still does just come down to license.
Yeah, and God forbid your supervisor is not a higher license than you,
then that's just really
or at least
slaves.
the equivalent license.
Which, I mean, happens. There's places where supervisors are EMTs.
Mm-hmm.
So, I mean, just keep that in mind that, like, our worlds just work differently.
For
Yeah.
sure. I know that was a tangent, but I just
We love
feel
those
very
here.
passionate
We do
about
love
it.
those.
So we've talked a lot about fire. What about law enforcement? That's our second most common friend on scene.
Yeah, so law enforcement and EMS. Law enforcement shows up to preserve safety and evidence. EMS shows up to preserve life. But our documentation can become evidence whether we want it to or not. And our interaction with law enforcement, to me, is super interesting because we have very different goals.
Sometimes they be
Very
really
different
mean.
goals.
Yeah. And, like, we can be crime scene eradicators. So we get there.
I will attest to this. I have absolutely
Mm-hmm.
fucked some shit up.
And
For the
especially-
greater good.
Yeah.
right, and like
Yes.
that has got to be so frustrating. I try really
That is.
hard. Yeah, I try really hard if we go to a scene where it is a shooting or somebody that is in cardiac arrest, and we're gonna do something about it. And afterwards, I try to document where everything was when we
Yeah.
got there and what we found. A lot of times we have to end up moving people from where they're found to like a
Open space.
workable space. So like sometimes there are like blood trails where we drag them
Yes,
and
that was us.
stuff like that. And to document like we did that can help police a lot later on down the road.
Yeah.
So on big scenes, like try to take it all in and document where things were prior to you moving them. There was an incident where a fire department,
This is interesting.
there was a very deceased patient. The gun was near the deceased patient. The patient was clearly deceased,
Very.
and dead people cannot shoot you. Fire department moved the gun from where it was, kicked it initially,
It gets worse.
picked it up, dropped the mag, cleared it,
It got worse.
It got worse.
and then put it in a different room. So like there was so much evidence degradation right there. Like, oh my God. But so this
That was
happens
crazy.
and
That was a
PD
little
gets
wild.
so frustrated with us, rightly
That's why.
rightly so. Yeah, and so I think that I try really hard to make sure I document everything as it was prior to our arrival or prior to our movement of things.
For sure. The one big thing I want to talk about in this law enforcement section is patient rights.
Mm-hmm.
Yeah.
And I think this is why Aubrey was excited about this, but I think it is so important because
Yep.
we didn't even know. Like, the three of us had to do like extensive research because nobody told us.
Yeah.
And we were just like paramedics running around on the street. So, Aubrey?
I think that like my number one takeaway from this would be, do not let law enforcement intimidate you into providing less than patient care. And by that, I mean, not that they are doing it maliciously. It is probably not malicious. But like James said, we have very different goals when we are on scene, right? So let's say that you get called out to a patient who was in a foot pursuit with PD. Okay, their PD's goal on that scene is to apprehend that suspect, to charge them with whatever crimes they are charging them with, and to take them to jail. That is not our goal on this scene. We are called out to, whether they frame it as like medical clearance or if they have 0 injuries. If that patient looks at you and says that they want to go to the hospital, I'm going to tell you right now, that is not going to make PD very happy, and rightly so. Like, that's not what they're trying to accomplish. That is going to delay their series of events that they have to complete. Our only goal and our only job on that scene is to take care of that patient, no matter what crime that they are being charged with, no matter what they are suspected of doing. They still are a human being, and they still deserve 1, humanity, and 2, medical treatment.
Humanity.
And I think that it is easy to be intimidated with law enforcement, even as something as simple as you have a critical patient, but maybe they don't realize how critical they are, and them asking you to like hang on for just a minute to get more information, or to I don't know, something that they need to complete to make their series of tasks completed. But that is delaying patient care. So like have the confidence to be able to verbalize that. Like, I am standing up for my patient. I'm advocating for my patient. I know what is best for them. And I'm going to treat my patient.
Yeah.
You cannot get in the way of that.
And I feel like some of them sometimes that happens really innocently.
Absolutely. I don't think that it
like
is
a
malicious.
perfect example is you have a super critical patient from an MVC. Let's say it's a pedestrian struck.
Yeah.
They're super critical. You're doing a lot of things. Law enforcement almost notoriously will open the back door and be like, hey, can you look for a wallet?
Mm-hmm.
And
like, this person's naked.
Right. And like they just want to identify them.
Absolutely.
But if you are... If in your brain, when law enforcement requests something of you, it is a command and you are required to perform that command at the moment that they ask you, that can impede your patient care. Because what if I'm putting on a 12 lead to kind of see what we got going on?
God forbid, what if I'm ventilating the patient?
Right, and I stop doing what I need to do to look for a wallet for law enforcement. It's an innocent request, but if your perspective is that you have to do what they ask immediately, then it's gonna impede your patient care. And so an appropriate response to that is absolutely when we get a minute. Like I can look for a wallet when we get a minute to try to identify them. And there are plenty of instances, even like, well, can we just take them to the hospital? If the patient is willing to go with you and does not want EMS to transport and is willing to sign a refusal, but patients still have the right to either accept or refuse medical care. And so even if law enforcement is like, they have to go with you, the patient can say no.
And it gets so, it's hard. It's so hard because we're not formally trained in the law, right? And they are formally trained in the law, or should be. So it's hard to go like toe-to-toe with somebody who is like, I am the law.
Yeah.
And I've been, and me and Ashley especially, we're just 2 tiny tots running around scenes, okay? They have been so mean to us. And I'm not saying all cops are bad or all cops are mean. I am madly in love with one, okay? And
Kelly Liggett.
Kelly's the best. And it just happens that there are some pretty aggressive people out there who are law enforcement officers. There's some pretty aggressive paramedics out there where I'm like, bro, chill. But it is something that you should never lower your standards because you feel scared.
Yes.
And that's really brave.
Yes,
thing
and we've
to
all
ask you to do.
seen the cases where PD has threatened to arrest a medic or an EMT on a scene for not doing what they ask, and that medic continues to stand up for their patient. And there's certain information that as a medical provider I cannot give you without my patient's consent.
Yeah.
So I can't tell you if I think they're intoxicated.
Please don't ask
I can't
us.
tell
Please
you
don't
if I
ask.
smell alcohol. And that puts me in a really weird position because I can't tell you anything about my patient's medical condition without
Right.
their consent. And it puts us in a strange place because we're co-responders with law enforcement. We work
Mhm.
together a
They're our
lot.
friends.
Yeah, we're
Yeah.
friends with them, and they come a lot of the times to keep us safe.
Right.
And so it feels like a betrayal when they're like, "Hey, do you smell any alcohol in them?" in like a 2-car MVC or something.
Yeah.
And for you to just be like, "I can't give you that information."
I just respectfully ask that you do not ask us questions that our patient privacy matters.
yes,
Just
that
please
make
don't.
us violate
Right.
HIPAA. I've even sometimes had some issues, not out of law enforcement, but I've seen it with my patient where they're not forthcoming with us with things that we need to know because
Right.
law enforcement's present.
Yeah.
And so like they'll get in the ambulance. And sometimes that's a strange conversation to be like, "Hey, can you guys step out? Because I don't think they're being honest with me because you're in here." And
Yeah.
we just had a patient like that. Now there was law enforcement had to ride with us. They were under arrest. They were cuffed. Like it was a situation where they had to ride, but I got zero information out of this person because law
Yeah.
enforcement was in there. And so he was okay. And they were okay and awake and all the things. And I was able to assess.
Obsessed.
I was obsessed with this. Never.
I was able to assess this patient like appropriately, but there was plenty of information that would have been useful.
Yeah.
But they would not disclose because PD's in there.
Yeah.
And that's their right to not talk in front of PD because they're under arrest. And so like it is such a weird dynamic.
It is almost impossible dynamic at sometimes. But there are just some like polite things that you could do as a police officer, in my opinion. Number one is, would you ever barge into a hospital room? Would you just open the door in a closed hospital room?
Should not.
They would.
Okay, but
Don't do that.
the answer is probably less likely yes than it would
Fair.
be in versus a,
Yeah.
like an ambulance. There's lots of reasons we keep the door shut. First of all, the patient could be in a trauma and we need to keep them warm.
Yes.
They
Climate
could be
control.
naked.
Yeah.
Like,
climate control, privacy,
Yes. Safety for us, like depending on what the scene is.
even noise.
Yeah.
Sometimes the scene is really loud and like it's hard to listen to lung sounds when there's 16 sirens
Absolutely.
outside. You know?
There are plenty of reasons.
But how many times
Yeah.
do officers throw open your back doors?
Oh man.
And it's 6 degrees
Please
outside.
Don't. Please don't do that. Also, yes, that's a good recommendation. If you are going to come into the ambulance unannounced, please use the side door.
Yep.
Because the patient is facing the back door. So, say this is a female we're doing a 12 lead on, or their chest is exposed for some
Mhm.
reason. That is now just available to the whole world, everybody who's driving by.
Mhm.
So just
Use the side door.
pro tip,
Yeah.
use the side door.
Use the side door.
Use
We're
the
family.
side
Use
door.
the side door. You
Yeah.
know what I mean?
Right. I would also say in reverse, honestly, like kind of for law enforcement, we are all very like on the scene, off the scene, on the scene, off the scene. Like we
Yeah.
want to get in and get gone. And there are certain things that law enforcement does need prior to us leaving. And so if the patient is not so critical that you have to escape immediately, like if the patient's chilling,
Yeah.
let's say it's an MVC, there's no critical injuries, but they're wanting to be transported. If you want to be like a nice human and your patient is cool with hanging for a minute and they're not like, get me off the scene immediately,
Yeah.
like then let law enforcement give them their like Titan for their toe and let them like get their information and things like that. Like we can work together in ways that don't super
Yeah,
affect
don't
us.
just like run away from the scene because you don't want to help law enforcement.
Yeah,
Like,
like
if you can stay on the scene for 2 minutes.
Yeah.
yes,
Probably just do
there's
that.
ways to be helpful, and as much as like we all kind of mess with each other, law enforcement's like if something goes wrong, you call us because you need us to keep you safe, and I'm like, oh yeah, but if something goes wrong, you call us because you need us to keep you alive. You know, like those are funny, but also like
Yes.
you want to have a good relationship with those people because if
Yeah,
you're in
don't
trouble,
screw people over because I don't even know.
yeah, if you're in trouble, you're in a dangerous situation, like something is going horribly wrong and you request PD, you want PD to be like, oh shit, it's
My
EMS.
pal, my buddy.
Yeah, not be like, ugh, blah, EMS, they're so
Of
mean to
course,
us.
they probably got themselves
They're
into
so mean
this.
to us.
Right. And in reverse, if you're an officer and you get critically injured, you want that medic showing up to have like some
Not that
some
anybody
stake in
makes
it.
decisions
yeah, no, like no one's
based
gonna
on how
not
mean people are to them.
no one's gonna not help you. But
Yeah, but,
man,
like-
you want them to have like some pep in their step.
Yeah, and they're probably gonna have better. They're gonna be nicer to you.
Yeah.
Probably if you are nice to them.
And that's just how the world works.
Right.
Like just be kind and people will be kind in return.
100%.
Unless they're trash buckets and then maybe they won't. But
Yeah.
Trash buckets.
yeah.
Some
But I
people
think
are.
that our interactions with law enforcement can be a lot better. But it's the same thing that I feel about fire is that if you are respectful, we can get a lot done.
Yeah.
It's not.
Mhm.
We are overhyping ourselves, I think, a lot of the times. And I think that's what it comes down to in almost every scenario, is that we think we're the most important people on the scene.
Mm-hmm.
And by we, I mean, if I'm a firefighter, if I'm
Yeah.
EMS, if I'm police, we think that we have priority over
Mhm.
everything on scene.
Yeah. One of the coolest things that we got to do is have friends that are in all different areas of like first response.
Yeah.
Mhm.
And so like we have friends on the fire department, and it's really cool to listen to their perspective and be like, yeah, but like this is what we're taught from like being like little tots
Yeah.
in the fire service. And so like that's why this happens. I'm like, oh, that makes way more sense. So I
100%.
can just communicate it this way and it will be received better. And they're like, yeah. And same thing with PD. They're like, oh, this is something that we absolutely are required to do based off of our SOPs. And that's why like certain call types, like
You're like, what
like
the heck?
strangulation, if anyone ever says they're strangled ever at all, like 2
It's
weeks ago,
attempted murder, guys.
they are
So that's why.
required. Yes, they are required to request EMS.
I'm pretty sure, right?
The officer is required to request EMS, regardless of
Yeah.
if the patient wants it or not. And that is like by their SOP. So it is not a point of discretion for
That's
them.
in our region. This could vary.
Yeah, this could be
Yeah.
different, but
This
just
is like
where
very specific to
just
this
where we
department.
are. But we used to get so irritated because
Yeah, be
there'd
like,
be
"What the
someone
heck?"
that's clearly fine.
Yeah, like 2 weeks ago, we're like,
Yeah.
are you joking?
I'm like, this is ridiculous.
Or we go to the police station because they're there
Yes.
to report, and obviously they got in their car, they
And-
drove there, and they're like, yeah, this happened to me last Tuesday.
Yeah, and they're fine. And we used to get so frustrated with PD until one of our friends was like, we don't have a choice.
I'm
That's
like,
literally our
"Oh."
protocol.
Like, we have to do it. And I was like, oh. Well, now I'm
Alright.
not mad at
It's
you
kind of
anymore.
like if
Yeah.
the hospital got mad at you every time you called a STEMI.
Yeah. Yeah, you're like, I have.
Code STEMI. Ugh. Why are you calling us?
Yes. I'm like,
Don't call me.
I
Don't
have
come
to.
by my house.
Don't come back here.
So there's certain things that we do with law enforcement that we get irritated with them about. That
Yeah.
like they don't have much control over at all.
Yeah.
Or it's a poor teaching in the academy, or like we had a string of law enforcement officers that called every single time an airbag deployed.
They did. Yeah.
That
Like-
was happening.
Yeah, they would
Yeah.
like bump a wall, and new cars, airbags deploy on like 5-mile-an-hour impacts. And so like they would like bump a wall and their airbag would deploy, and they would immediately call EMS even though the patient was like,
Up walking around.
I'm fine.
Yeah.
I called my own tow truck.
Mhm.
It would be things like that. And that is just education based. Like they did not realize that that's not something they had to do.
One of my favorites ever, and I genuinely find joy in this. I thought it was so funny. Ashley and I went on a call for an MVC upgraded. They were already moved to a parking lot. There was actually really no damage or anything, so that's why they moved to the parking lot. Everything was fine. It happened like 30 minutes before. The passenger of one of the vehicles walked up to one of our favorite law enforcement officers and said, "Is my nose bleeding?" And he was like, "I don't know." And he called us. And I just thought it was
Can
funny.
you see if that man's nose is bleeding?
I do
I was
not
like,
know.
It is not.
Unknown.
I would like to kind of flip the script on this for just 1 second, then we can move on to the
Yeah.
next section. So we have been talking about this as the perspective of like working with law enforcement, right? I would like to point out that I think that it is just, as a human, sometimes difficult to walk up to a patient who is restrained in handcuffs and is complaining of a medical complaint, and to always 100% take that person non-biasedly and to treat them accordingly. And I would challenge you to pretend that handcuffs are not there. Because not even of the fact, like, I'm staring at you and you're in handcuffs, so obviously you did something wrong. Not always the case. But also, like, it makes your life more difficult to get a 12 lead,
It
to
is hard.
do interventions, to get an IV. Like, it does, to a degree, or it can impede the practicality of you doing certain interventions.
Yeah.
So I would challenge you to maybe rearrange handcuffs in a way
Mhm.
that is not an issue, and maybe just pretend that they're not there, so that we are not biased toward people who maybe didn't even commit a crime. We don't know.
Right. And that's the thing, is that even though like you know these people and you know we're friends with PD and things like that, we still have to understand that like even if somebody is being arrested for something, they're innocent until proven guilty in a court of law.
And
So like
also,
it does not necessarily mean PD may have even given, it may be innocent. They may have just been given horribly bad information, and now
that's
they're
what I
still
was gonna say.
they're still investigating. This
They're just
person's
detained or whatever.
detained, and they're having a medical event and have requested you, and they haven't even figured out what's going on yet. There's so many different scenarios where we always approach it, and we're in the South, so sweet baby honey angel is like how we interact with these people. And obviously you want to do this with like discretion and make sure that you're safe and make sure that PD is safe. And if they're reporting that this patient was like wildly combative with them, that's okay. Talk to your patient and
Sometimes
see if PD,
they just don't like the police.
yeah, and see if PD can restrain them safely in another way.
Yeah.
Maybe they do need to stay cuffed. Maybe they've had an elopement risk and maybe they do need to stay cuffed. And that's okay. But see if maybe we can cuff them in the front. See if we can talk about restraints with a stretcher. See if we can talk about...
That's my favorite.
Yeah. See if we can talk about different ways to manage this. Have officers ride with you. Because there's a risk with cuffing somebody in the front that they can use cuffs as a weapon. So like...
Please don't let them convince you they don't need to ride.
Yes. It is okay.
Cuffed,
require them to ride. Because you need to be able to release those if anything bad happens. But like it's okay to have these conversations and be like, I would prefer them be restrained this way, and in order to mitigate that risk, I would like for you to ride with me.
9 times out of 10 they will, especially the cuff arrangement.
Yeah. And there's only a couple times where they're like hesitant, but most of the time if you just talk to them about it, they'll do it.
Yeah.
But you are allowed to do those things and to request those things, and it doesn't matter how frustrated or irritated PD is with this person and what they have allegedly done. You still have to treat them like you are a blank slate.
And you're allowed to tell them no when they request things that are
not allowed. Mm-hmm. Like you're still here for this person.
Yeah.
And sometimes it's not easy to do that, but like you gotta.
The last thing I will say is if you take everything that we just said and you go watch body cam footage of Elijah McClain, maybe think about how that case would have turned out different. Okay, moving on.
But true.
Moving on.
You just need to stand up for... Sometimes you're the only thing left when it comes to advocacy.
Yeah.
Most of the time you're the only thing left.
Yeah. And like everybody's human. Everyone gets elevated and heightened. If you respond as a second officer to your partner getting the shit beat out of them.
That is scary.
Right?
Yeah.
And
but that's why you don't need to make decisions right now. It's our turn.
Right? And if you are like super physically aggressive with this person, we get there, they're injured. Like there's a lot that can happen. And a lot of it is just human nature.
Yeah.
That's fine. But now we need to be able to make decisions for this patient. And you need to be comfortable and confident enough to be like, hey, we will no longer be doing that.
Yeah.
There's plenty of scenes where you have to be like, you have to rearrange PD. Like, hey, do not restrain them that way. Don't stand there. Don't kneel on that. Like, there are so many times.
That's what I gotta say.
Yeah, we're going to sit them up. We're going to do X, Y, Z. Like, there's a lot. And you find a way to do it respectfully so that you can maintain a good relationship with PD. We did a clinical challenge at one of the schools that are local to us, and basically it was a patient that has a hypermetabolic behavioral emergency. They are very large and very strong, and it was basically an example. It was a social comment on how you interact with PD and how helpful they can be, and sometimes how hindering they can be. But essentially the medic had to talk with PD and interact with them so that they could work well together. They needed PD to reposition the patient so that they could breathe appropriately, but they still needed PD. And there were plenty of paramedic students that got there, and they thought the point was to basically tell PD to fuck themselves. Mm-hmm. They did that. They showed up and they were like, kick rocks, buddy.
Get out of here.
But then they couldn't. Scram. She doesn't want to talk to you. But then they couldn't manage that patient, and it ended up being a huge safety issue.
Yeah.
Mm-hmm.
And so like you have to be able to do it tactfully in both directions. And I think that that's a really important skill that EMS needs to learn, because we are almost the only ones of the first responders that are like the catch-all, right? We have multiple roles. We are responsible for every human, regardless of like the state they're in. Like it's just a very unique situation.
Yeah,
for sure.
And I think learning how to communicate with different agencies that you perceive to have more power than you do.
Yeah.
Is an interesting task. So like you got to practice that.
I will say a lot of confidence. You can gain a lot of confidence from doing what is right for your patient.
Yep.
It will.
Like if that is at your forefront, my God, you will say anything with your chest. I promise.
Absolutely, because you can justify it.
Yeah.
Moving on from the police.
What if it's not a co-responder? Here we go.
Right. What if it's not? What if it's somebody else?
Sorry, that we could have a whole episode, and actually we are going to have one pretty soon.
Oh,
so.
good.
Surprise! Surprise! So, what about hospitals? So, our scene doesn't end always just in the ambulance bay. Like, sometimes, first of all, sometimes we're holding the wall, and we have to continue to carry on patient care for
Oh my
a
gosh.
long time.
How
in the
many
hallway.
times have you gone back to the truck to get another oxygen tank
Oh,
because you're still
yeah.
holding the wall?
Mhm.
Yeah.
Oxygen meds, even.
Yep.
Mhm.
So sometimes that is where it starts too. So we can have those scenarios where we are maybe, holding the wall, or maybe there's just not an expeditious exchange of care. Sometimes that is literally where it starts. So hospitals obviously are making life or death decisions based on what EMS is telling them, and EMS can be called when life-saving decisions are not able to be acted on at those sending facilities. So in the
Mhm.
case of transfers. And I think that this is a hot topic for EMS because we're exhausted. A lot of the times we are understaffed, we're run ragged, and we're running more calls than we should, and then you get thrown a transfer. And crickets because, yes.
Because
You're like, oh my gosh, this better be good. This better be good.
you better
right?
you better mean it with your
That's what we're
chest.
saying. And sometimes it's not good.
Sometimes it's not.
So what do we do? Truly, and imagine we're in a system where you just have to take it. You don't get a say.
Mhm.
There's nothing you can do. You get assigned the call. You must take it.
Yep.
You get assigned. We're going to talk about a couple different extremes here. But one of them would be you get assigned a call. It comes out as an emergency transfer. You show up to the hospital. There's a person in the bed. They look unfazed. They are just chilling. They're not even in a hospital gown. Maybe they're still in their jeans.
We're just hunky dory.
Yeah, they're not even on the cardiac monitor. That's
Oh,
interesting. That
hmm.
happens a lot, right? What do you do? You do it anyway.
Smile.
Yep.
You grin and bear it is what you
Yeah,
do.
you just
and
do it. And
I
if
would
it
like to remind everybody that the patient
didn't
did
ask for
not
this.
request
Had
your
nothing to do with
did
this.
not request you, because sometimes you'll see providers be really snippy and short with the patient, and this is not their decision,
Why'd you even come to this hospital?
right?
Because it's
don't
a hospital.
so don't do that. Don't do that, and don't be mean
To the nurse.
to the nursing staff, because guess what? She also didn't really make that decision. And don't be mean to the physician, even though you want to, because they're probably being dumb.
Maybe he's just scared.
Yeah.
Maybe he's like, I need a paramedic.
Maybe this is a teeny tiny.
Yeah, maybe.
Maybe this is a teeny tiny rural hospital, and he's a primary care doc that moonlights as an ER physician.
Literally, that happens all the time. Maybe it's the middle of the
Right?
night, and the floor doc is the ER doc.
Right?
I've done those before.
For sure. And so things happen, but I understand being salty about it, but try not to be rude.
Right. And if there is some kind of process, or even not, after that call is run,
Mm-hmm.
it would be maybe a good idea to create some kind of document and submit that to your leadership and say, we were called for an emergency transfer. Emergency. And the patient required no equipment. They had an IV in place, and that was it. Our concern is that, because there are situations where
Yeah.
they'll call and the weather's bad or whatever, and they're like, well, we didn't want them to. I've had that. Austin and I have had that where they're like,
Yep.
it's snowing, so we didn't want them to drive to Nashville. I literally got my driver's license at the time, 5 years ago. No, I'm just kidding.
Yes, I'm
That's
like,
very
oh,
extreme. But
have you guys seen us drive?
you want me to drive instead of the dad in his truck that is actually 4-wheel drive?
Yes, that's like a dually that's
Yeah.
weighted down with a,
Yeah.
It's already got chains on it.
Yeah.
And you're like,
right. You're like,
all right, we got it. We got
Mhm.
it.
Yeah, I think that sometimes it is appropriate if there's a moment of education, take
Yeah,
it.
yeah.
If there's a moment to be like, hey guys, in the future, this is a better way to handle this.
We have this non-emergency
Yes.
line.
If there's a way to be as far as emergency, non-emergency, if they don't understand what the difference is,
Yeah.
it's not just who comes, it's how we train, it's all the things.
Doctors, and I run into this at my ground critical care a lot,
Mm-hmm.
some of them, newer ones especially, think emergency is ALS and non-emergency is BLS.
Mhm.
I've run into that actually several times. So that is actually
Yeah.
a great point of education.
Yeah.
And you can even approach it as hey, you put this as emergency, but there's no special equipment. Would you be okay if the advanced EMT rode with this instead of the paramedic?
Yep.
And then they'd be like, oh, yeah. well, I just thought, and then that's
Yeah,
when
I
you
just
take the
needed
moment. I
them-
approached it as a question.
Yes, I just needed them to go right now.
Yeah.
And I'm like, okay, also out of my hospital right now versus lights and sirens down the interstate
Yes,
are
different.
very different things. And so transfers are definitely a point of contention for sure. What do you do? So not in the world of transfers, but what do you do when you get into the ER? You have X amount of interventions that you have done, and nursing staff is being negligent of those interventions.
This happened to last shift.
What do you do?
His pacing wires got cut.
I think what I run into a lot in the ED is that we will come in cardiac arrest, humeral IO.
Yeah,
And
guys.
there is poor education with nursing staff around humeral IOs. And they will take that arm, they will sling it all the way out,
Look for an
like
IV.
straight up into a T to look for an IV. And they have now risked shearing that catheter, and so you should no longer use that IO. The problem is that they don't have any other access. And so, like, if I haven't gotten multiple IOs or IVs or whatever it is, they have now destroyed their only access. So you now have an extremely critically ill patient that you have been negligent with their only access, and you've now sheared it. And it doesn't matter how many times.
And they might have to have that, like, surgically removed if
yes.
they live.
It doesn't matter how many times I'm like, do not move that arm. They do not care. And so we have started putting, like, literal tape all the way down the patient's arm that says, do not move.
Yeah, that's smart.
IO in place, do not move.
Oh.
Oh, they still do it.
I take Coban.
I'm like, hey, did you read that? And they're like, oh.
I started doing this, but I put Coban on their wrist, and instead of putting them on the CP, if there's space, this I've luckily had only small patients because I work in an aircraft now, but I will Coban their wrists together and put them inside the CPR device.
Oh, yeah.
And it works fine.
Yeah, I like that.
Yeah. Highly recommend.
Because that is such an issue that we have where there's an appropriate time to address it, and it's not screaming at a provider while you're in the room. And so I think that...
Please just don't stop life-saving interventions.
Don't.
And if IV access is required for the IV or the life-saving intervention, please be cautious.
Yeah, like sometimes...
Assess that and then move them.
Right. And sometimes we don't have IV access in, like, say like a respiratory failure that's turned to an arrest, sort of cardiac arrest, whatever. Sometimes we don't have IV access because we couldn't establish any because it was really difficult.
They're dying.
And so now they're in cardiac arrest, which means you have meds that you have to give at least every, like, 3 to 5 minutes. And you can't because you have now destroyed the only vascular access that exists. And now you can't get a line.
Yeah.
And I get so frustrated with it because it is not for lack of trying. Like, we have tried so hard to educate them through this, and it is so frustrating because it basically undoes so many things that you've already done.
Well, that's why you can make fun of the model all you want of, like, the hospitals that have, like, the squares on the floor that says where everybody stands, and there's a method to that. That is what saves lives. Checklists save lives. Methodology saves lives. Repetition saves lives. Doing things the same way almost every time.
Yep. When you have a bunch of random hospital staff run into a room just grabbing and throwing and doing things, you lose tubes, you lose pacing wires, you lose so many different things.
I've seen it kill people more times than I even want to admit, and it's frustrating, especially when you've worked so hard to keep that person alive. That's the worst, when they are still alive.
Right.
And you did everything you could, and all by yourself, and then a bunch of grabby hands just come out, and scissors.
And they just start cutting
It's like
off.
a nightmare.
Oh, I mean, I've had monitor wires cut, stretcher straps cut, like, what?
They just start slicing everything off, and I'm like, hey, everybody pause. And
There's
been even things like we had a arrest with a ROSC, had levo hang in, had done like quite a bit of things. Pressure was in a good place, like we were perfusing well. We ended up sedating because we like had some like purposeful movement, like it was going quite well. Well, we get to the ED and we start discontinuing fluids. They discontinue the pressor without anything else in place.
I don't know why they do that.
So they just
either.
immediately start removing everything from the patient. And like, okay, but I had a pressor going for like a reason. And then they get cycle of pressure and it's 50. And I'm like, yeah.
Because you stopped their
like,
pressure 5 minutes ago.
Yeah, they say, were they hypotensive? And I said, not when I brought them in here because they had levo hanging. But now they don't because you DC'd it without replacing it with anything.
And I think there should be...
And I'm like, oh my fuck.
Some kind of training we do together, right?
Mm-hmm.
And also, like, I know. So ACLS, for example, is essentially made for the hospital.
Yeah.
Have y'all seen how they do that? That is how you need to handle every critically ill patient. I don't know that ACLS is great for pre-hospital
Yeah.
as a general rule because there's so many dynamic things that change every single time. It doesn't change. Our movement rarely changes from one
Mhm.
bed to another. How you transfer care, do it that way.
Do it
That
that
is actually great.
Yep.
Watch that video.
Yeah, and it makes it so much easier. So I think that point is important. And like when you are the EMS provider, like
Report it to.
yes, report it, stick up for yourself, advocate for your patient.
Give good reports. Be honest. Be kind.
Yep.
Hold the line.
Hold the line.
Yeah, is there a difference, real quick, between a radio report and a bedside report?
Oh yeah. Please do not
Please,
stay on
God.
the radio. Sometimes, you know what? I hate it when you're giving a really long radio report on the way to the hospital. And I know people listening to this. There's plenty of people who don't use radios, which it's very integral in our region. We use radios to car report. We use radios all day long. But I know there's people that don't. But we do, and when we do, there's only so many seconds you can talk. And if you are giving this correct, because sometimes you do have to say a lot of these things
Yeah.
because the trauma center you're going to requires them or whatever, and if you don't say it, they're going to ask anyway. And you're giving your report, and it does the beep because you've gone too long. I'm just like, dang it. I get so embarrassed.
You're
Embarrassed.
like, that's probably
Short and sweet.
Yes. Yeah.
Just do what's required of that
Yeah,
facility.
they do not need, because remember that radio reports are a heads up, right?
Mhm.
So they do not need like a super in-depth,
No.
we found her and here and like all the things, unless it is like reasonable because like you need to be deconned or something.
Yeah.
Like make sure that you are just giving a brief synopsis of exactly what they need to know in order for them to be prepared for your arrival.
Yeah, the things that they are trying to determine from your radio report is where does this patient need to be placed, what room in our ER, and what specialties need to be present when you show up. That is
Mhm.
it. That is all the information that they are looking for.
Why do mismatches with your radio report and your bedside report destroy credibility? Like what could be some...
Mismatches, like as in your story doesn't line up.
Yeah, like let's say you call it in
And it sounds
and it
really
sounds
bad.
super critical.
And then they're
Like you're running emergency traffic, like all this stuff. You get there and your patient is relaxed. They're compliant with the intervention. They're A-okay. And they're like smiling at them. They're like, hey there, honey. Like why does that...
it's like crying wolf. A little
yes.
bit.
Like why does that severity matter, or that mismatch level of severity matter?
I think in the best terms that we can understand it, it's the same phenomenon as people calling 911 for us. Like our expectation
Yeah, you're like,
on
yeah,
the initial
yeah,
911
yeah.
call is not that you're dying now at this point in time. Our expectation is that you have a general medical complaint unless otherwise stated.
Mm-hmm.
Yeah.
Right? And I think it's the same thing with hospitals. If you run in emergency traffic consistently, or maybe you make a big to-do on your radio report and then you come in and maybe that is not the case, then it's the same thing. You maybe aren't going to get specialties. I'm not saying that this is correct. I'm just saying this is the reality of the world that we live in. You maybe aren't going to get the specialties that are needed for that patient.
Mhm.
You're not going to be taken as seriously, all of the things.
Absolutely. Because again, it's not that it's hospital policy or anyone's taught this way. It's human nature.
Yeah.
If I hear your voice on the radio
You sound
and
freaked out.
yes, and I know that you're always yelling, you're always
You're
over,
just like, oh, it's so and so.
right? You're always overexcited. You're always running silly things in hot, like, I don't know, a nosebleed or something. They're going to get really used to you and they're going to stop taking you seriously. And that could have negative outcomes for your patients.
Yeah. I think it all comes back to one of my favorite phrases is that if you're a voice for other people, you have to be a voice that can be heard. And
Yeah.
that I think
Yeah.
applies to like several different things, like literally your communication style, but also like if you're a voice that nobody listens to, you're not a voice that can be heard. And that gets in the way of your patient advocacy.
Yeah, for sure.
All right, let's talk about nursing homes and long-term care facilities.
Mm-hmm.
Nursing homes, the arch nemesis of EMS.
Da, da, da.
The comic book series.
I like that.
It is very easy to get very frustrated, especially if you are zoned near
Mentee, a nursing home.
many a skilled nursing facility.
Just to be so frank and honest, like, so many nursing homes are just trash. They're just bad.
Understaffed, staffed with people who are not in it to win it.
Yeah, like they maybe don't care about their job, or it's just the only one they could get, or whatever it is. Like, a lot of them are bad. There's negligence. There's poor patient care. Some of it is because the providers don't care. Most of it is because they're so poorly staffed that they don't even have like a chance. Like, we always are like, oh, so you've been here 7 hours and you just came in to check on this lady.
Correct.
But maybe they have 38 patients to 45 patients to do med passes on.
Correct.
And so, like, most time they're only staffed with one RN. If it's an RN, it may be an LPN. So, like, they're trash, but because they don't have any resources.
Yeah.
Yeah.
Like, it's by,
They're
like,
just deserted islands where they send
like, the
old
staff is
people.
really set up to fail a lot. That does not mean that sometimes their behavior is justified.
Documentation. One time I was involved in a homicide case at a nursing home.
Mm-hmm.
I had to go to court.
My biggest issue is when you lie to me. So I don't care that you are so understaffed and you are not able to get in this room for the last 5 hours, and that this person has been dead for 5 hours.
Please say that, because also that will hold accountable, if this does go to court, the agency that you're working in.
Absolutely. But don't tell me that you
us.
talked to them 10 minutes ago
Yeah.
when they are fully rigored.
No. Yeah.
Don't do that. And
Please don't.
what about our favorite phrase?
This is not my patient. I just started working here.
Mhm.
Or
It was
I don't
just
even
shift
know
change,
them.
even though it's 3 a.m.
I've
Right.
never had them before.
And I get it. It might not be your patient. You
Then
may.
why are you giving me a report?
I don't know.
Whose patient is it?
You may have just
Where
started
did you
working
come
here.
Who are you? Are you work here?
You might not even work here.
Show me your badge.
But every single facility has a record of these patients.
Mhm.
So if it is not your patient, educate yourself on them. If you don't know what's going on, find someone who does. Like,
Get their
I'm not
paperwork.
concerned that you don't have answers. Most of the time, I'm irritated that they're unwilling to find them.
Yeah. Well, and the thing is, too, I feel like most of the time we show up and it's either the most minimal, tiny, itty bitty thing, like why are they even going to the hospital? Or they are literally deceased and we just found out about it right now.
Mm-hmm.
Correct.
There really is no in between.
Nope.
So that extreme nature of like the back and forth of nursing homes can be exhausting.
You just never
Yep.
know.
You never know. And I would just please ask, if you are in a facility or you work with a facility, communicate with them about your expectations when you pick patients up. Please have all their paperwork ready.
Yeah.
Please have their post form. Are
Yes,
they a DNR? I need
please.
to know that.
Right? And there are certain things. I understand that sometimes there's a very short window between recognizing you need to call 911 and us being there. Sometimes that's like 2 minutes.
Ideally,
Yeah.
yeah.
Yeah, and if you don't have their paperwork ready, I get it. But like, let's have a plan in place for how to locate that, how to copy that, how to print that. A lot of times it's not necessarily that someone's just trying to do it. It's that they don't know how to do it.
Mm-hmm.
And so it takes so long. Because we've all been in these facilities that are like good at it.
Oh,
And
yeah.
we're always surprised.
They just should probably already have one printed
Yeah.
in case of emergency.
Right? Like, every time we'll walk in there and they'll be like, here's your paperwork and this is what's wrong, and they're in respiratory distress, and you're like, oh, they're critical and I have everything? And you're like, that's crazy. We had one not too long ago where the nurse was phenomenal.
Oh, yeah. She was great.
She was on top of it. She knew everything about this patient.
Wow.
She knew
That
exactly.
makes me gobsmacked and
Yes.
excited.
She knew exactly what interventions had been performed. She knew what time they had been performed. She knew last known normal, and she had all the paperwork ready. And I was like, where did you come from, you
I would
angel?
like to take you
You angel woman.
and multiply you and give you to all the nursing
And
homes.
sprinkle you around.
Yep. I think that it's also important to remember that, much like with hospital to hospital transfers, remember that the patient that you are going to pick up probably had absolutely nothing to do with you being called, aside from their medical ailment.
Yep.
It is all staff judgment, provider judgment, and very, very rarely is it patient requested.
Yeah.
So
Don't be mean to each other.
don't be mean to the patients.
No.
Don't be mean to the nursing staff, honestly.
Yeah.
But
There are moments where things
I know.
are. I know. There are moments where things are absolutely egregious. And I have been known to get sassy with a nursing home nurse or two.
just know you're going to have to do super sleuthing.
Right? And you're gonna, like, it is so much easier to ask them pointed questions. And you can get your point across by still being nice.
If you ask repeated, direct questions that have a literal yes or no answer, and their answer is I don't know for every single one, that gets the point across.
Yes, it does. And if you need to know something, find the CNA.
Yeah, they
Yeah.
probably do know
I'm
more.
telling you right
They
now.
really are with the patients more.
Yes.
Mhm.
If you need to know something, find their CNA because they will know their baseline. They'll probably know their mom. Like, they will know
Yeah.
everything going on.
Yeah, they will probably know their mom.
Yeah. If I need paperwork, I find the nurse. If I need to know something actually about the patient, I find the CNA.
Yeah.
Mhm.
Yeah, be kind. Understand that you're probably not going to get all the information you desire, but also that would be the same scenario if you were picking a patient up in their home. So just understand the system is broken. You're just living in it.
Yep. And being a jerk to them,
It doesn't help.
it doesn't help. It doesn't make
They're
you
just
feel
gonna
good.
hate you more.
Yeah. It doesn't make them feel good. It doesn't make you feel good. It doesn't get anything done.
Yeah.
Like, I'm the first one to admit that I fall into that sometimes because
Yeah.
I get frustrated. It doesn't ever help.
No, they just resent you.
Yeah, they storm off. You still don't have your paperwork.
And now you got no hopes of getting it.
I have no post form.
So those are kind of the most common interagency communications and discussions and interactions we have. But what about, there's a few more we want to talk about.
Ooh.
And I know this episode is forever long, so sorry about it. You can watch it in parts. But what about mutual aid and regional responses? Some agencies, this may be more frequent than others.
Yeah, we don't have a huge amount of experience with this because we're a decently large agency. So it is with a lot of municipal responding agencies that are fire-based. So, like, we don't have a whole lot of need for mutual aid. But
When I worked rurally.
yeah, but when you're
You're
rural,
like, are we there yet? No.
yes, and you only have 2 or 3 ambulances and a huge county, like, that's tough.
Yeah.
Yeah.
But when multiple agencies respond, ego becomes the greatest threat to patient care. Especially, like even if it's a multi-agency response because you're, like,
Yeah.
on a county line and they send,
Both
other-
ambulances,
yeah,
both
both
fire
fire.
departments, both police departments.
right? And it gets really hairy.
Yeah, I think that either you're gonna have crews. I say most of the case, you're gonna be like, it's your patient,
Mhm.
not ours. It's not ours. Or you're gonna be doing a mutual aid, where suddenly both of the county's ambulances went out of service or went on a call at the same time, and then all of a sudden a third call comes out, and it's like a freaking cardiac arrest, and your response time is now like 40 minutes.
Mhm.
That is literally so real.
Yeah.
That has happened to me.
Yep.
And it's terrible. So just know, like, if that is a situation you've gotten yourself into,
Yeah.
because you work where
If you work really rural
Yeah,
or whatever it is.
where
Yeah.
it's rural, be so prepared. Know what you're about to do. Know that it may be a good time to auto launch.
Yeah.
If you don't know what's going on, you may need to call there's a chance, and
They'll
this has
just
happened,
beat you.
they might beat you, and
Mhm.
that's okay.
Yeah.
It
That's wild.
just depends where you're working and what part of the country, but that does happen. That happens in West Tennessee sometimes. Air will get there first.
Yep. And in mutual aid situations, make sure that there is some kind of plan, and defer to whoever's going to be your command. So, like, let's say that it's not just you're mutual aiding another county.
Volunteer
Let's
fire
say-
department.
Yes. Or that it's like a disaster
sure.
scenario where you've got a lot of agencies going to one place. Make sure you know who command is because somebody's going to be command.
Make sure you know the radio channels you should be on.
Yep. And if you're at the start of that situation, make sure that you find a command, set up a command, make somebody in
Yeah.
charge, because that's going to help a lot of the breakdown issues that a lot of time comes with mutual agency response is that you need to have a representative from each agency that then is with the person that's in command so
Yeah.
that everybody can communicate appropriately. And if we learn that large scale, so that way we can understand it on a small scale and use it in our, like, daily operations, it gets much more functional.
Yeah, having systematic approaches to things really does help because it can be translated into the simplest call or the most complicated call.
Right. And that's why ICS is a thing,
Mm-hmm.
because this happens and there has to be a procedure for how to handle, like, a
Yeah.
huge interagency response.
Yeah.
Absolutely.
And for your counties that are around you, that are close, that you're likely to be mutual aiding, make sure you're interoperable. Make sure there are ways for you to communicate.
And we all know that agencies may form a reputation, whether it's they're pretentious or they're lazy or whatever it is.
Yeah.
Those are the extremes of the scale. Don't go into these calls where you may be working with multiple agencies outside of your own, maybe that you've never worked with your own prejudice.
Yeah.
Because that is going to ruin everything. Just Go do your job. Y'all are all there for the same reason. Be
For sure.
respectful, and I think that's the bottom line. We've talked about this whole episode. Just be respectful.
Because
clear.
that other medic or provider may be exactly what you thought that they were going to be, or they
Yeah.
may be exactly the opposite of what you thought. So just give everybody a chance to like prove themselves.
For sure. And then one agency that you may work with that we don't every day, especially in our region, but you may if you're more rural, is flight services.
Yeah.
And I think this is actually a super important one to talk about, especially when it comes to communication. So flight crew communication, it starts when we're still in the air. So knowing how to prepare and report patient updates, I think, is often missed. And our agency in our region, people are really good at it. And there's usually one person who's responsible for doing it, like the supervisor. That is generally not the case, I've learned. That is absolutely the exception to the rule. But
and people, I feel like people don't teach you how to do it.
No, but it teaches you that. No one teaches you that.
Right? Like if I did not
I had to learn in
moonlight
the other
in
county.
Yeah. If I did not like moonlight in supervisor role, I don't know what channel to go to. I don't know how to set up I in theory know how to set up an LZ. But like how do you want me to tell you about like phone wire, like electrical wires and stuff? Like what do you want to know on a report? Like there are just so many things about flight that they don't teach you.
Yeah, and we're going to give you the little skinny version. But some of the most important things are everyone's safety, right? So LZ is a top priority of like making sure it's a safe space.
And if you just sick a fire department or a sheriff's officer on it, they'll do it.
They own it.
They'll do it.
They really are pretty good at it.
Yeah.
And they, especially in rural
They'll do it
areas,
so
they
hard.
have a really close communication typically with these flight teams. But just know that if you're landing in a field that's just been cut, that is important. There's a bunch of loose hay down here. Some of those fields are really treacherous. You cannot get a stretcher across them. Like, just know.
Some of them are very mushy.
Yeah, just know those things. Let's identify wires. Let's try to pick a place, even if we have to move from our original scene. And I think that's generally a standard. We're going to have pre-listed LZs. Y'all will probably have pre-listed LZs on the ground, or your dispatchers will. You can ask for that information. When I worked at a really rural service, we just had a book of LZs that we could flip through, and often we would just transport our patient from the scene to the LZ. And honestly, that's probably the safest bet for everybody involved. If you need help, ask for help. We can land without you telling us anything. That is not ideal, but it can happen. Make sure there's no animals in your field if you're landing in a field. Yeah. They can get a little rascally. Some of them will charge the aircraft, which is wild to me.
Oh my gosh.
It does happen. And then if you're giving a report, this is the most important information I want to give you, because there's probably someone on that scene that can help you out with an LZ, or we can help you out with an LZ, or dispatch can help you out with an LZ. We want to know your patient's weight.
Mm-hmm.
We want to know what happened to them. Because of how air operations work, we know nothing. We go to the aircraft, we bring all of our things, including blood, and we just go on the flight. We do not get any information until we're already in the air. So we would love to know the patient weight, adult or pediatric. We would love to know what happened to them. Is this medical or is this trauma? If you have a patient height, that's really creme de la creme. And then when we get into your ambulance, there's almost always a paramedic. So we've done the job. We are just going to do what we would do in any other circumstance of handing over care. It's probably going to be way less stressful than if it's at the hospital, because we're all on the same team here and we've all done the job. So don't be stressed about giving a report. We just want to know exactly what you would give it in any other report. What you've done, what happened, how what you did affected the patient, and what we need to do next. And we will talk to you. We will talk to the patient if they are able to speak to us. It's going to be chill. I promise. It's going to be chill. But if you are giving an in-air report, please provide weight of the patient and the mechanism or illness. It's just so helpful, because we can't bring the whole aircraft
for sure,
to
just like
the ambulance, right?
Yeah. Just like it's hard for us to bring every single thing we could possibly need.
Right, into the house.
Yeah.
And that's the
Absolutely.
same thing. And it's really hard to do some of the interventions that we would love to do in the ambulance while we're in the aircraft because we don't have as much space to access the patient.
Mhm.
So it is nice to be able to bring the things.
Yeah, for sure. And I
We
think
do.
that this is something that I have run into with flight crews is that initially when I was first a little baby medic, they would get in the truck and I would be like, sir, yes, sir, what do you need from me?
Yeah, we are all the same. It's okay.
And now that I like, have my critical care and I'm like a bit more grown, I will be like, oh, stand by there, Skippy.
Yeah.
Because sometimes we will be mid-intervention when flight arrives.
Yeah.
If that happens to you, respectfully request that you complete the complete the intervention without interruption.
If it's an appropriate intervention, no one should stop you.
Absolutely.
And if they're trying to stop you,
Yeah, like
they're
we've
wrong.
had air land and enter the unit while we're mid RSI.
Yeah.
And we'll be like, hey, we are mid RSI. Are you on board with us completing this procedure? And they will be like, continue.
please finish that.
Absolutely.
I'll be
And
like, yes. I'll be over here.
Yes. And if you run into problems with any flight crews, I promise you their agency wants to know about it.
They would do want to know about it.
So have a conversation. Talk to your supervision. Talk to their agency. Talk to them about however anything went down. Like, it is still, communication is still going to be your best answer for any interagency issues you have.
Yeah, and I think that there's definitely a fallacy of authority. We have this flight suit on. We are just providers just like you guys on the
Mhm.
ground. I still work on the ground and in the air. It's the same job.
Yeah.
The circumstances in which you operate in are different, but it is the same job. And we make mistakes too. We have unfortunate egos too. We have bad apples too.
Oh,
So,
yeah. Everybody does.
yeah. Make sure you're packaging your patient if they're ready to go and you don't have any loose sheets or blankets. Make sure not your helmet. Make sure that your hats are off if you've got a hat on.
Yep. Sunnies.
Yeah. Anything that could fly away, put it away.
Because it's going to fly away.
Yes.
It will.
And then we
Mhm.
won't be able to fly away because it'll be on our tail rotor.
Oh,
Yep.
God.
Mm-hmm. And then you're going to be double trapped with your
Yes.
patient. Then you're going to have an angry flight crew and a patient.
And a very bad
Yeah.
pilot.
And a very mad pilot.
Well, that was a lot. Thanks for hanging in there, guys. Every call you run is bigger than the patient in front of you. It becomes a story told by radios, reports, cameras, charts, and memories. And EMS is almost always the narrator, whether we mean to be or not.
Fire will remember how you treated them. Police will remember what you wrote. Hospitals will remember what you handed off. Nursing homes will remember what you questioned. Flight crews will remember whether they could trust your assessment.
And long after the sirens stop, your documentation will still be speaking for you.
Co-agency response isn't about being the loudest voice on scene. It's about being the most reliable one.
Because in emergency medicine, trust is currency, and you earn it one interaction at a time.
So the next time you step onto a scene full of uniforms, remember this. You're not just practicing medicine, you're representing EMS to every system that touches the patient after you leave.
The job you do is super important, and we're really proud of all of you, no matter what uniform you wear. All right? So we'll see you next time. This was Life in Sirens.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.